Hi, good morning, everyone. Welcome to our ST-115 Unit 6 discussion. Today we're going to be talking about anesthesia and death and dying in the OR. This is not like the most fun topic to discuss when we're talking about death and dying, but it is an important topic to discuss because if you stick with this career long enough, it's something that you will encounter. So it's best to kind of get ahead of it now and get your mind wrapped around that fact. So we will be talking about different like coping mechanisms and how we can handle those types of things when it does happen. We're also going to talk about Maslow's hierarchy of needs and different anesthesia techniques and things that you're going to see with how that affects the patient really. So here are your assignments for this week. You do have a project due that is worth 90 points. So make sure you're getting those projects in because they are weighted differently. Okay, so they're not in the same category as your discussion posts or anything like that because those weigh more, these types of projects. So if you don't turn that in, I promise you it will drop your grade significantly, and then you'll be emailing me asking me, can you make this up? Okay, so make sure you get those types of things in. If you have any questions about any of those, please let me know. Okay. Also, go back and respond to two of your peers each week in your discussion posts. That is honestly the thing I think that I take the most points off is not going back. And those add up over time. So you don't want to end up doing that. Okay. All right. So how do we handle the loss of one of our patients? Um, that's not an easy thing to really even put into words. Some people will handle it better than others. Um, Personality does kind of play into it, but to say it won't affect you at all is probably lying. It will affect you in some way. Some people will use it for good and to, try to spur that into making them a better surge tech or a better, doing something better for the next patient. Okay. So it is difficult. And we have to remember that anytime a patient comes in the OR, it's possible. So I've had a few of my patients die on the table. It is difficult. It's important to remember that that person belongs to somebody, right? You can't become hardened over it. And it will affect you. It'll affect you for years. I still think about those patients and their families. 10 years later, what would they be doing, right? So, but it's important to kind of cope in the moment and then reflect on it later because the next patient needs you too. That's what's important to remember. You can't let it completely devastate you in the moment because you still have another patient, right? That patient, that next patient in your room still deserves your 100%. And if you are too distraught to even focus, they're not going to get your 100%. So it's important to remember self-care. I don't think you should bottle it up. It's important to talk to people who understand what you're going through. So your OR team, the people in your room are going to be people you can depend on, rely on, talk to. So use those people as your resources. All right. So you're going to see some of these terms when we talk about death and dying in the OR. Some patients come in with what's called a DNR, do not resuscitate. Okay. They can sign this particular paper that says they don't want to be resuscitated in certain instances prior to coming to surgery, or they don't want any like extra types of care. If they're coming in for maybe, let's say, a lesion removal on your local and they code on the table, maybe they don't want to be intubated, right? It depends, that's their choice. And we can't judge them for that. If we don't agree with it, that doesn't matter, right? It's not our choice to make. Every patient has the right to choose. They have the right to determine their healthcare. So, advanced healthcare directive is another type of document that we really don't see as search text, but if you're ever a patient where your nurse may say something about it, It is a written document that is a little more explicit. It states your specific wishes that you want regarding your patient care when you can no longer make decisions on your own. And typically someone is appointed your medical power of attorney that would make those decisions for you as well. So a living will is going to be a little bit different than your advanced healthcare directive in that it is a legal document that really can say more about what you would want um, near death or with the prognosis of death. Um, so they kind of go hand in hand a little bit. And then we have this lady down here, Elizabeth Kubler-Ross, who is a psychiatrist, or this has been, I think, from the 70s, but proposed a theory of stages of the dying experience, which is not going to be the same for everybody. So this thing that she created basically is kind of called the grief cycle or the stages of grief and dying. And these are typical emotions that most people will feel when either they're given a prognosis of death or maybe the family will feel in maybe a passing of their loved one. So you have denial, anger, bargaining, depression, and acceptance. Now, it's important to remember that not everybody goes through every single step, start to finish. Okay. Some people might be stuck in denial for the rest of their life. That's just how it is. They might be angry for the rest of their lives. I think we've probably all heard of instances about that. Maybe you've experienced that. And it's important to remember that maybe even once you get to depression, the next step may not necessarily be acceptance. Okay. You might go all the way back to denial or anger. This can be fluid. It's not a start point and an end point. It could go back and forth. It is a bit of a roller coaster, right? So you might even experience this as a search tech when you lose a patient. You might be angry. You might be angry yourself or your doctor. You may have thought, well, we could have done something different, right? Be frustrated. Um, I mean, I've felt that. It's hard. So um, you kind of just rely on your team. You move on. You realize your next patient needs you. That's my biggest piece of advice. So ethical considerations in death and dying, you have two things. I kind of mentioned this one before. Self-determination. Everyone that comes into a healthcare facility in the US has the right to make a decision on how you live and how you die. If you want to die without any tubes or any life-saving measures, that's your choice, right? And we have to, as search techs, honor those wishes. We can't impose our own will on what they've already chosen. Okay. Some might still want palliative care as a part of their end of life care. So palliative means you're making them comfortable. You're not necessarily going to cure their illness, but you're going to make the end of their life more comfortable. You can give pain relief, things like that. Now, the right to die is referring to like refusing treatments that we may think could save their life. Maybe that's not what they want, right? But we as healthcare workers cannot refuse to treat them, but patients can refuse treatment. So it is not a two-way street. We still have to treat them until they refuse the treatment, but we cannot refuse, okay? No matter if that patient was an inmate who murdered people, it doesn't matter. You might have that. I've had inmates come in, we do surgery on them, we treat them like any other patient. It's probably best if the circulator just didn't even tell you anything about that patient's background except what's medically necessary. Sometimes it's easier to focus that way. So how can we as healthcare workers deal with death in the OR? What are some coping mechanisms? It's important to have healthy coping mechanisms, not other types of coping mechanisms that I think most tend to go toward. I would highly recommend some sort of debriefing period where maybe the same people that were in that OR with the patient that passed, maybe meet just briefly even after work to discuss, what was it something that could have been done differently? Was it a sentinel event? Did someone mess up that led to that patient's death? If so, that needs to be addressed so it can be fixed. So having an organized support group with people who understand what you're going through is very important. Now, I would also still recommend talking to someone you trust, even if they don't work in the OR. It could be your spouse, child, whoever, best friend. Having that person that you can go to is going to be important. Okay. Medical discussions, some big facilities will do like a big debriefing, but it is important to discuss the limitations of medical care. We can't save everybody, right? We cannot control all situations. We are human. Um, I think we get so used to just helping everybody. That's really why we go into this field. We want to help people. So when we see something that can't be fixed or that we can't help a person, it is frustrating and it kind of feels like we're not doing our job. So we have to just understand that there are limits, there's a reason why things happen the way they do, I believe. All right, expression of feelings, healthy expressions, don't bottle it up. So again, going back to finding someone you can talk to in a healthy way. And self-care, speaking to a confidant, have a work-life balance. That's a hard one to not take those types of things home with you and let it affect your home life as well. That might just take some time, some practice, and some self-reflection, really understanding your limits, maybe. That does take some time. All right, here's some other key terms when we're talking about anesthesia. Um, the term anesthesia, that second one, actually means without sensation. A lot of people just assume it means being put to sleep, right? That's kind of a misconception, but remember here in your midterm, A means without, or A-N. So without feeling is what that truly means. So that's one of our goals of anesthesia, is to make sure our patients don't feel anything. We want them to be pain-free, which is analgesia, absence of pain, which we can do through different types of drugs. Amnesia, the inability to recall events. So there are two types of amnesia. You have retrograde and anterograde amnesia. So when we give patients, maybe let's say a sedative, like a benzodiazepine in the holding area prior to the case, they will experience anterograde amnesia. So what that means is once we give that drug, they're not going to remember anything after that drug. Okay. That's why a lot of patients think they were put to sleep in the holding area because they don't remember anything after that. Now, if you fall and hit your head and you don't remember what happened to you from when you hit your head to when you were little, like you're 8 years old, you don't remember anything, that's retrograde from behind, anything in the past, right? An anxiolytic, referring to anxiety here, a drug that reduces anxiety. Sometimes if we can reduce a patient's anxiety, we can limit the amount of pain meds they need, which is good. It's kind of a balance there. A bear block is a type of extremity block, like for an upper arm. So it's in the category of regional anesthesia, where an anesthetic agent is injected into a vein, usually up in the upper arm, like the subclavian maybe, to block the extremity. So we could do that for like a carpal tunnel or a hand surgery, maybe elbow. That's probably the best options there. A laryngospasm, you'll see this or hear about this a lot when we start doing clinicals, because this is a concern when we are intubating patients and extubating patients, when we're putting the tube that helps them breathe down their trachea and when we take it out at the end, because it's like a trigger response. If things are too loud in the room and you're banging instruments around or whatever, it can actually trigger a laryngospasm, because the patient's sense of hearing is the last of their senses to go when they're being put to sleep. So it actually causes like an autonomic response in the body that can trigger that larynx, your voice box, to slam shut, which will obstruct their airway. Then they can't breathe. Then it becomes an emergency, all right? Especially if they don't have the airway secured. So you want to be super quiet. when we're intubating, excuse me, and extubating patients. So these three here at the bottom are types of anesthesia. How do we approach the type of anesthesia that a patient needs for each case? You have general anesthesia, which is being put to sleep, right? That's like completely under, associated with the state of unconsciousness, coupled with giving pain meds, anxiolytics, muscle relaxants. Now, a MAC stands for, excuse me, monitored anesthesia care. So it is kind of the, if you ever heard the term twilight stage or like a twilight anesthesia, they're not fully asleep, but they're kind of out of it. They're out of it enough that we can kind of do what we need to do without putting a tube down their throat, an ET tube, right? So if you're doing like a colonoscopy or an EGD, you could put them under MAC instead of a general, if necessary, possible. And then topical is just numbing the superficial nerves of the skin or mucous membranes, but this is the key, motor function remains. So if I need to take a mole off the back of the hand, we're taking the mole off, let's say it looks cancerous. They're just going to inject, let's say lidocaine, sensorcaine, bupivacaine, something like that, into this underneath the skin on the back of the hand that would only numb that area. It doesn't go to anywhere else in the body, right? It is not systemic, but the hand still moves. Okay. Now up here with your beer block, the arm would be motionless and also pain-free. General anesthesia, motionless. Typically with MAC, for the most part, they're motionless, but they could still move if they kind of come out of it a little bit. The topical is no motor function. So our goals for anesthesia when we're putting patients to sleep are these things. We want our patients to be unconscious. We don't want them to be awake. Okay. We want them to be pain-free, immobile, like motionless, and we want them to have amnesia or no recollection of what has happened to them. You've heard the horror stories probably of patients being awake under anesthesia or having that recall. That means maybe the balance of drugs was not right for that patient. I always say anesthesia is truly like an art form. It's not something I could ever do. I have the utmost respect for anesthesia because I have to find a perfect balance for every patient to accomplish these goals. And it is tricky sometimes. So we also have something called the phases of anesthesia as well as stages, which is the next slide. So be very careful when you're referring to these. They can be tricky, phases versus stages, because they involve different things. So the easiest way for me to remember is that a phase is something you go through. Like I went through my emo phase or whatever you want to call it, right? You go through it. You come out the other side, hopefully. So the phases of anesthesia is what the patient is going through until they go to recovery. So they start with pre-induction, usually where we give them 100% oxygen. They come into the OR, put them on the bed, hook up all their monitors, and then induction starts from when we start to administer drugs that will cause the unconsciousness, right? And it ends when the airway is secured, whether that's an ET tube or an LMA, a laryngeal masked airway. Maintenance, the phase here, maintenance is when we actually do surgery. And that's been a certification question before. In what phase of anesthesia does surgery take place? It is maintenance, okay? So this typically is the longest part of the whole process here, right? When we're doing the work. Now, emergence starts as soon as the surgery is completed. We put the bandage on, sutured, everything, and we start the extubation process. So emergence starts with the end of surgery and concludes with the extubation and the airways secure as well. And then recovery starts when we take the patient successfully to PACU. Now, typically as surg techs, we don't do that often, but I mean, I have a few times if they needed an extra hand, but once the patient goes to PACU, then we can clean the room up, start over, get ready for the next pre-induction patient. So those are phases. Now here are the stages, okay? So I said phases you go through, like your emo phase. Now stages, look at the last one here. It's actually, the last stage is death. Medullary paralysis is where your medulla is where your breathing and cardiovascular centers are. So if you fall off the stage, let's say, you could die. I know that's kind of a terrible way to remember it, but that's how I remember the difference between phase and stage because they're so like similar in terms, but they are very different. So a stage of anesthesia, stage one is analgesia, getting rid of their pain. The stage two is excitement stage. This is where they're most at risk for that laryngospasm that I mentioned before. The last sense to go is hearing here, okay? Stage three is similar to the maintenance phase. All right, this is where we actually do the surgery. Different things happen to the body, muscle relaxation, pupils dilate, etc. Now, here's where it becomes an art form for anesthesia, making sure they don't go beyond stage three into stage four. It really is, because stage four can lead to death. You've given too much drugs that lead to medullary paralysis. Your medulla is part of your brain stem that controls your breathing and cardiovascular centers. Okay, so make sure you understand the difference between phase and stage. So the concerns for us as search techs, why do we need to know about anesthesia, right? For one, we have to understand the types of anesthesia, like I talked about, MAC, general, local. Typically, they're listed on your surgery schedule. Sorry, my air just picked off. Because it does affect how you might set up for a case, or even how you arrange the room for a case. So you need to know those things. You can look at the schedule, or sometimes it changes. Ask your anesthesiologist what they think they're going to do. You can assist with anesthesia whenever possible. If you are not scrubbed in and sterile, if you're free in the room as an extra set of hands, you need to be up by the head of the patient anytime anesthesia is like intubating or extubating. They always could use an extra set of hands to just hold something, or to just withdraw the stylet out of the ET tube. You're allowed to do that. Always be quiet during induction and extubation. Like I said before, you do not want to cause a laryngospasm, which will close off their airway. That is bad. So if you're being noisy, anesthesia will yell at you. I've seen it happen lots of times. Be aware of the patient's level of consciousness. So sometimes if your patient has a MAC or a local, they can still, or even honestly general, they can still possibly hear what you're saying. So you've heard those horror stories, like I said before. Maybe the patient was a general, but they could recall explicit conversations that happened in the OR that may have been about that patient. Sometimes people are mean. Okay, I've seen some surgeons say some pretty nasty things about patients once they're put to sleep, and I think it's disgusting. Don't be that person. Don't talk about people when they're asleep, because they might be able to hear you, and if they do, they can sue you. So, and it goes back to just knowing, or just being aware that that patient belongs to somebody, right? That's somebody's person. You need to remember every time a patient comes into the room that you should be thinking that that's your person or your favorite person on the table. That way you wouldn't treat them like that. Okay? Always be prepared for emergency situations. Anything can happen in the blink of an eye. The case could be going perfect, smooth sailing, and then 5 seconds later, maybe they code. Their heart just stops for a reason we don't understand. You have to know what to do in a split second. So in the case of a code, if you're scrubbed in, you're sterile, you got your stuff set up, your number one goal is to protect the sterile field. Okay? Because if they get the heart rate back, they're going to want to close that patient up. They need the sterile field to do that. If you're not scrubbed in and a code comes, the patient starts coding, you can either help with chest compressions. You need to be CPR certified, or you can go get the crash cart. Okay, we cannot get meds or draw meds, but we can do those things, which are also very beneficial. So know where your crash carts are as well. You need to have knowledge of drugs used on the field for anesthesia purposes. We're not at the head of the bed injecting anesthesia meds, but we do draw up medications used for like your locals. You'll have lidocaine, xylocaine, bupivacaine, centrocaine, marcaine. I mean, there's a ton of them. And if it goes through your hands, you are responsible for it. Okay? I cannot stress that enough. Just because we're not injecting it doesn't mean you don't need to know about it. You're going to pass it to the surgeon when it's appropriate, and you're going to tell that surgeon what it is that you have. So be very mindful of the drugs that you have, when and where they can be used, because that's something that if you don't know, you could accidentally kill a patient. So you need to know your pharmacology. So another emergency situation you might encounter is malignant hyperthermia. Notice it's hyper, not hypo, okay? Hyperthermia. So this is when the patient's body temperature becomes insanely high. Okay, so I made this little handout. I give it to all my students. That just kind of breaks it down in a simple way of what MH is. You have early signs and late signs of what you'll see with the patient during an MH crisis. The first one you're going to see is an increased, where it says ETCO. Increased ETCO stands for end tidal CO2 or carbon dioxide. They're going to have an increased amount of carbon dioxide they're breathing off. They're breathing out from their lungs. Because what's happening on a cellular level causes an increased buildup in carbon dioxide in the body, because it's actually kind of breaking down some of the muscle. It's a genetic condition, or it's where it says here, what is it? It's a genetic syndrome or condition associated with certain general anesthetics that can quickly kill a patient if it's not identified soon. It happens very rapid, okay? So sometimes patients don't know they have this. That's why we ask for their family history, because if your family history, if they've ever had reaction to anesthesia, you might also, okay? And if that's the case, they'll just choose different drugs. The drugs that trigger malignant hyperthermia, right here, triggering agents include succinylcholine, senectine, which is a muscle relaxant, and inhalation anesthetics that end in A and E, ANE drugs. So for example, sevoflurane, desflurane, isoflurane, those types of drugs with succinylcholine can trigger MH. Okay, it's all like a cellular level thing. It's like chemistry, okay? Once it's triggered, I mean, you have maybe 15 minutes to respond, if that. You're going to start to see these early signs pretty soon. Increased in tidal CO2 because of the breakdown. Carbon dioxide is usually a byproduct of cellular metabolism, things that happen on a cellular level. You're also going to see muscles start to like clamp up, right? Or they'll spasm, masseter spasm here in the jaw. You're also going to have tachycardia and tachypnea, an increased heart rate and breathing. Your body's trying to get rid of that carbon dioxide really fast because it becomes basically like poison. If you have too much carbon dioxide in the blood, it becomes acidotic. You have acidosis. So we need to get rid of that metabolic acidosis. It takes a little while in the relative span of time here. You'll see an increased body temperature, and it could go all the way up to like 106, 107 degrees Fahrenheit, which is way too high, right? It could kill a patient. But the increased body temperature is not usually an early sign. It's like a mid to late sign. So late signs, you're going to see mottled cyanosis, where they like blue patches-ish. DIC stands for disseminated intravascular coagulation, which is basically when your body makes a lot of blood clots really fast, and then your blood has used up all of its clotting factors, and then you basically bleed to death. Okay. So it just keeps getting worse. Cardiac arrest, hyperkalemia, so it really affects the kidneys. Treatment, you must know, because you can actually be in charge of mixing the drugs, because dantrolene, the drug of choice here, or dantrium, is it has to be reconstituted. So you'll have a vial of powder and then you'll have your vial of liquid that has to be combined into something that can be injected into the IV. So that might be your job, is to reconstitute dantrolene, which they need a lot of vials for, okay? Because the dosage is 2.5 milligrams per kilogram of the patient. So your vial may only have, um, I don't know, like 10, 50, I forget what it is, what the vial is, but so sometimes you need up to 30 milligrams per kilogram. So the dose is high and they have to keep giving it. Actually, they keep giving it over the course of like 48 hours. So the amount of dantrolene they need is huge. In our area, because we're in a smaller area, this doesn't happen very often. Our facility doesn't even carry the amount of dantrolene that we need to treat a full MH crisis. So we actually have to go to other facilities. We have a like a contingency agreement where we go and get those and then order more as soon as possible. Um, it's crazy, I know. Because you have to get it pretty quick. You also hyperventilate with 100% oxygen. Obviously discontinue, these triggering agents. You need to also cool the patient. This could be something else you could do as a surge tech. If you're scrubbed in, patient's open, sterile, you could be getting a slush machine, like get some sterile water, make it into slush and put it in any body cavity that you have open. You can also have people get ice, put it under their axilla, their neck. You can put it in the rectum, whatever you have to do to get their body temperature lowered, will be life-saving, honestly. So these are some of the treatments. There will be, I can almost guarantee it, a certification test question about MH. They love to ask that question. Either what it is, early signs, triggering agents, treatment, the dosage of dantrolene. They've asked that before. So I would memorize this if I were you. Okay, just saying. There is also a number, if this ever comes up, maybe it's midnight and you're on call, you don't know what to do, there's not enough people. You can call this hotline. This is a real hotline, the MH crisis hotline. And they'll walk you through it, which is pretty cool. All facilities should have a malignant hyperthermia like cart ready to go with everything you might need to treat an MH crisis. If your facility doesn't, I would encourage you to talk to your management to have one ready, to get one set up. That would be a great thing to do. You just never know. All right, so that's it for this week. If you have any questions, please reach out. You guys are doing a great job so far. We're in week 6 here, so you only have, after this week, one more full week of classes, of assignments, because week 8 is kind of like a half week. It's like a roundup week. So be getting all that stuff in, and as you turn it in, I will get it graded. So let me know if you have any questions. Bye.